Hello, everyone, and thanks for joining our Tools for Success, How to Increase Clinician Satisfaction with HIT Solutions. My name is Jordan Leibovitz, and I am part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. If you have any questions, please type them into the questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well, and we'll get to as many questions as we can, but if for any reasons yours is not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive for those attending, so throughout the presentation, we will be launching poll questions for you to answer. Today, our Chief Medical Officer, Dr. Andrew Kanter, will be speaking. As mentioned before, if you have any questions or comments while Dr. Kanter is speaking, please type them into the questions on your GoToWebinar control panel. With all of this being said, I would like to pass it over to Dr. Kanter.
Hi, everyone. I'm Andy Kanter, and as Jordan mentioned, I am the Chief Medical Officer for IMO. I'm an internist and global health specialist by training, and I've been with IMO since it's been founded in 1994, and I've seen a lot of changes to the health IT landscape. I joined Columbia University in 2006 in the Department of Biomedical Informatics and Epidemiology, and I lead the Columbia International eHealth Laboratory, where I see how eHealth is impacting global health, particularly in low-resource settings. I'm also a member of the board on global health and the National Academies of Science, Engineering, and Medicine. Today's webinar is going to focus on the changing regulatory and health IT landscape and how it is impacting clinicians and their relationship to technology. I hope that I will be able to share a unique perspective for you and help you identify strategies and tools for success with your clinicians and HIT partners. I'll begin by giving a brief introduction to IMO and our history, and then move into a description of some of the challenges we clinicians face, followed by some predictions of how new regulations will change the data landscape, further exacerbating this love-hate relationship between clinicians and technology. I will then introduce a possible new paradigm which could help us overcome this challenge, and then end with some recommendations and QA. So IMO has been a critical partner in helping clinicians capture their clinical intent within the health record for over 2 decades. We have focused on delivering value by powering care as you intended. We do that by building our platform on 3 pillars: intelligently, intuitively, and intentionally. And we are now providing tools and solutions to help unlock value further up the information chain. Many of you probably know IMO. We've been the primary driver behind clinical interface terminology. We began in 1994 when few clinicians were even using medical records. Today, we are the premier supplier of clinical interface terminology to the US and English-speaking market, with more than 70% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the US alone. This experience gives us an important perspective on what challenges clinicians are facing today. The introduction of clinical interface terminology increased EHR usability, and it allowed clinicians to interact meaningfully with these new tools. This was at a time when there were high hopes that technology would significantly impact the triple aim. Introduced in 2008 by the Institute for Healthcare Improvement, the triple aim had 3 objectives: to improve the patient's experience of care, to improve population health, and reduce per capita healthcare costs. However, we have really failed to make significant progress on the triple aim. We could look back on this failure and see a negative synergy between technology and the addition of regulations upon healthcare systems and the providers. Once it became clear that clinical interface terminology could help clinicians effectively use health information systems, and that these systems could then be employed to implement programs to reduce costs and increase reimbursement, the documentation demands on clinicians began to grow. Physicians became the sharp end of the spear for all data-driven efforts. In fact, one initiative after another has burdened clinicians without providing significant benefit directly to them, including reimbursement and compliance scrutiny, meaningful use, and the physician quality reporting system, the introduction of IC10-CM, and the switch to value-based payment models. We are in the middle of rising expectations that clinicians are going to have to manage. And now everything is about artificial intelligence and machine learning, new payment models, and personalized medicine. But if we don't address the underlying interaction between the clinicians and technology, the system will break. We know that clinicians are spending more and more time with the technology. Unfortunately, it is not the sort of engagement that we require. A recent study in the Annals of Internal Medicine described how physicians are now spending more than 16 minutes per patient with the EHR, which consumes much of their day and even extends into their quote-unquote pajama time. The passage in 2015 of the Medicare Access and CHIP Reauthorization Act, commonly called MACRA, was a logical step in the movement away from fee-for-service to a more value-based federal payment program. The final rule, which came out in 2017, implemented the MACRA initiatives focused on quality, information, and cost, but a key component was missing: this new type of engagement for clinicians. The National Academy of Medicine paper published about the same time put forward the idea that a continuously learning health system with engaged clinicians is what is going to be required for success. For some, this imperative has prompted an evolution of the triple aim now to a quadruple aim, highlighting the need to focus on improving the provider experience, an objective that will require careful thought and disruptive technologies. Simply put, transforming the relationship between clinicians and the health system must begin with transforming the relationship between clinicians and technology. And that means re-envisioning how the technology collects, presents, and uses data for all users of that data. Unfortunately, things are about to get a lot worse. The 21st Century Cures Act, which was passed in December 2016, had some good intentions. And I'm not going to go into the details of the act itself, but the Office of the National Coordinator, or ONC, who is responsible for authoring the regulations called out by the Cures Act, released a notice of proposed rulemaking in 2019. And with the intent of, 1, increasing innovation and competition, 2, reducing burden and advancing interoperability, and 3, promoting patient access. This proposed rule generated a lot of controversy, probably heard about it, over concerns about patient privacy, among other things, and the final rule has not yet been released, but it's probably expected this month, perhaps while President Trump is speaking to HIMSS. Once enacted, it is expected that health systems and health information technology vendors are going to have 3 to 4 years to comply with these new regulations. 2 of the rule's objectives will potentially have a dramatic change on the information landscape. The first is the regulations increasing technical interoperability of health information technology. Now, this effort has been in the work for many years, but the focus on ensuring that technology can more easily pass information between systems in an understandable way will accelerate adoption. And this includes creation of a minimum data set that must be supported and a standard way to transmit that data between systems using technologies like the Fast Healthcare Information Resource, or FHIR, or Consolidated Clinical Document Architectures, or CCDA. But the regulations not only address the technical reasons for why information is not flowing, they also focus on the providers. Decreasing information blocking prevents health systems from erecting barriers to data flow, like adding costs or contracts that block the sharing of information. The result of these 2 efforts will likely be to create a data tidal wave. Clinicians and data analysts, already burdened with trying to unlock value from massive amounts of data, are now going to have even more data to deal with. Also required by the 21st Century Cures Act, a strategy document for reducing burden was released by the ONC. It includes recommendations about dealing with information overload, and it is clear now that addressing clinician burden will need to be a priority.
Thanks, Andy. Now we're going to do a poll question. Which of the following challenges are you most concerned with? Just a few more seconds. All right, thank you, everyone.
So dealing with the data tidal wave and the potential for swamping our providers will require a new paradigm that takes into account the provider's experience, and there are ways to do this. First, we can no longer view health IT primarily as a passive data store or siloed EHR-bound data. We can no longer only emphasize the back-end user value, such as reimbursement or risk scoring, and not place more emphasis on the needs of providers. And nor can we continue to expect providers to bear the burdens of all this data collection and then expect them to just blindly reach into this huge bucket of data and find out what they need when they need it. We can see the EHR and all health information technology in a new way, as a communication medium. We can understand how the data needs to change to provide value to all users. EHRs should be viewed as a communication medium between users and not only as a data store. Today, most care is provided as a team effort. EHRs must facilitate the efficient and effective communication between providers and other providers. More and more, the EHR and patient portals act as a bridge between providers and patients and their families, and patients and providers. And finally, something many people forget, the EHR is the fundamental way that I, in the past, communicate with myself seeing the patient today. How do I know what I was thinking the last time I saw you? What has happened between now and then which might change my thinking now? If we are to set up a solution for all data consumers, and especially clinicians, we need to recognize that the data we are collecting in all of these different ways does not necessarily support how that data actually needs to be used in a particular situation now. If we're going to manage the tidal wave of data, it must be aggregated, normalized, transformed, and then summarized for each context to unlock value for providers and other data consumers. And I'm going to talk a little bit more about that now. To see what I mean, particularly as it relates to improving the provider's experience, we need to understand the data journey to value. To start, we need to have a comprehensive view of the patient. Clinicians are not going to trust the information that they see if they don't think it's reliable or complete. Data will be coming in not only from the EHR directly, but from ancillary systems, other EHRs, and even the patient, him or herself. All that data coming in from all those different sources needs to be syntactically normalized. In other words, formatted so that it can be understood. And then it has to be semantically normalized so that the same data is not represented in redundant ways, or that data that is conflicting can be easily identified. Once the data is all in the same format and has a similar meaning, and is at the highest level of specificity possible, the data must be transformed to be quickly understandable to the user. I'll give some examples in a minute, but the data as collected is likely not in the format that will be of use in other use cases. And finally, the massive amount of data that will be available to the clinician will need to be summarized and prioritized if it's going to not overwhelm them and increase their cognitive burden. There are many possible examples of data transformation. I have spoken about a few of these documentation issues in the past, and when you document disease states in the medical record, they can be quite specific. For example, IMO has 14,000 different ways to capture diabetes mellitus or variations of it in the medical record. If I want to trigger a rule to ensure that all my diabetic patients all have the proper hemoglobin monitoring or eye exams, I have to roll up all of those diabetes together. And the definition of diabetes used for that rule is actually a different definition of diabetes than the diabetes diagnoses, which might be the exclusion criteria for a rule to use, let's say, a beta blocker after a heart attack. Another example of transforming and summarizing is the pre-op or perhaps the pre-op check. Let's say that I want to send my patient to have his gallbladder removed. How do I know that he's okay for surgery? Do I want to scan his entire chart? I really just want to know that his heart is okay, his lungs are okay, and his blood clotting is okay. Can the computer just pull out the latest EKG, pulmonary function test, and coagulation panel for me to review? And why make me translate these results, which were performed perhaps for another reason? If I know that a platelet count is less than 50 means that they can't go to surgery, dramatically reduce provider burden and allow information to be presented in a context and workflow sensitive manner.
All right, at this time, please refer to your screen for the next poll question. Which of the following do you anticipate will have the biggest impact on provider satisfaction? Select all that apply. All right, just a few more seconds. Thank you. I'm going to close out.
So healthcare today is at a critical juncture. We are already straining under the demands of big data and oftentimes poor quality data. The high hopes of artificial intelligence and HIT have not had the impacts that we had hoped, and the providers and the very system itself is on the verge of breaking. Add to that this potential tidal wave of data unleashed by new regulations, and we have a very real threat. I hope that I have given you some new ways to think about this data problem. And now, let me give you some recommendations for success. We can convert this tidal wave of data into a force that really can improve care and the lives of our providers. First, technology must be seen as more than an administrative data collection tool. EHRs and HIT that act more like communication mediums or tools will be more provider and patient friendly. We can understand the aggregation, normalization, transformation, and summarization steps that will truly make data useful and reduce the cognitive burden on our users. We can work with colleagues and partners to formalize definitions for these transformations using interoperable value sets and explicit definitions. And we can partner with your technology vendors before the tidal wave actually hits, so that we can deliver care the way you intended. And I hope that IMO can be one of your partners to make that happen.
All right, this will be one of the last poll questions. So if you could refer to your screen and please answer. Would you be interested in learning more about IMO solutions that improve the provider experience? All right, thank you, everyone. All right, at this time, we'll start our Q&A session. If you have any questions from today's webinar or questions you had coming into the webinar, please enter them now and our team will begin answering questions live. As we start receiving your questions, please excuse any brief silence for our team to review and answer.
Okay, question came in. What do you think it will take for the medical community to embrace the quadruple aim? Well, I think that it depends on who you really ask that question to. I think the physicians for some time now and the providers have asked to be included in this value proposition for some time. I think that there's a greater and greater recognition now that the failure of the triple aim and the ability to actually achieve many of the outcomes that we've been looking for is primarily because of this different value proposition between the providers and others. So I do think that this is gradually improving, and if we look at that, for example, that strategy document that ONC put out, it really does put the provider experience front and center into new design, and I think that that will likely make it easier for not only the providers themselves to see that the system is changing, but there will be greater incentives for the people who provide information technology to include that in their design process.
Just a reminder, if you have any questions, to please put them in the Q&A box.
Another question came in. Can you provide a real-world example of the steps or technology an organization has implemented to improve provider satisfaction? So I think one area that we've seen a lot of uptake about is in reconciling information that is been entered into the medical record. So typically, particularly as internists or anyone who's seen patients with chronic conditions, they're confronted with problem lists or lists of diagnosis that can read pages and pages of screens. I think just organizing that information alone to provide information about the various problems based upon specialty or organ systems that might be relevant to me when I'm seeing the patient today dramatically reduces the cognitive burden of having to review that entire list, and certainly also makes it less likely that important diagnoses will be missed by me when I'm seeing you today. Another example that I think that we have seen is that the ability to filter information in the medical record based on the problem orientation is another very important way to deal with sort of information overload. So where in the medical record the various procedures, lab results, medication history, and so on that revolve around the particular problem that I'm dealing with you today, being able to quickly pull that information out has been a great improvement. There was another example of where recently where dealing with the information that was coming, for example, from a health information exchange in Indiana, being able to, in the time that a patient comes in and sees me now for something like chest pain, to quickly pull that health information exchange for the relevant pieces of information that might impact my diagnosis and assessment of the chest pain is another really powerful example of leveraging this type of aggregation, normalization, transformation, and finally that sort of summarization and prioritization that has been successful in the past. And one more question here, and it was, what does IMO actually offer that will dramatically improve the provider satisfaction? I think I mentioned a couple of things just earlier on, and where we've actually partnered with others as well as IMO itself. And that has to do with, one, around the problem list organization, and being able to have your EHR, for example, be able to better organize problems in terms of the problem list and the diagnoses with IMO Core is one example. In terms of the transformation required, some of the ones that I mentioned earlier in the webinar involve appropriate grouping or summarization of data, and there IMO's precision sets are a curated way of ensuring that the definitions for things like diabetes, for driving particular clinical decision support, or maybe other quality improvement programs or pre-authorization for surgery can all be done in a way that dramatically reduces the cognitive burden and automatically syncs with the data that's in your health information system or EHR. And then lastly, I think what's really interesting, the ability to dramatically reduce the work required to pull out the appropriate information in the medical record is driven by the appropriate use of those precision sets. So the ability to summarize and filter the data regarding a particular problem that's on the patient's chart, or even perhaps, let's say, a problem that I'm thinking about that's not on the patient's chart. And these are three ways that which I think IMO can help facilitate that process of normalizing, transforming, and fundamentally summarizing data for the providers.
Okay, and before we close out today, we have one final poll question that I'm going to launch. Would you recommend this webinar to a colleague? All right, we're going to go ahead and close out for today. We hope you found this information in today's webinar useful. If you want more information on IMO Core, please contact your IMO client executive or email sales@imo-online.com. Thanks for attending and have a great rest of your day.